Good afternoon, everyone, and welcome to our webinar today. I'm Tom Glinsky, Chief Inspector with the Board of Pharmacy, and today's webinar is our HealthNet Pharmacy Program Update. Today's presenter is Olivia Rush. She's PharmD. She's a Program Integrity Pharmacist at HealthNet, and Joshua Moore, who is the Director of Pharmacy at HealthNet. So I welcome both of you again back today for a webinar. Thanks for coming. If you've never been on our webinars before, you are in mute, listen-only mode. If you have any trouble connecting, if you're on a web browser and have any trouble connecting to the audio, you have an option to dial in and not use computer audio, and on your toolbar, I'll give you the dial-in instructions. This program's been approved for 1 hour of CE by the Board of Pharmacy. You must be signed in under your own username in order to get CE. You cannot be sharing sharing login with someone else, or you cannot be listening only by the telephone to get CE. At the end of the program, I'll give more instructions on CE. And just a reminder, we do not submit to the CPE monitor, so save your certificates. And if you're using this for other states, don't assume they will accept this. You should check with them first. If you want handouts of the slides today, there's two places you can get them. The first is on the board's website under the upcoming events tab, and then that'll take you to a link showing you where all the webinar handouts are. We now are posting all previous from last year's there. You can get past ones there too now. The second option is on GoToWebinar. If you're using the web browser on the toolbar, if you go down to the tab that says handouts, there'll be a PDF there of that. And then if you're on the mobile app, you have to click the more icon and then the materials icon, and then under materials, the webinar handouts will show up there. We do record our webinars and post them on our website. It can take maybe 15 days before they show up. We hope to have time at the end to take some questions from our participants. We ask for them to be submitted in advance. We'll work on those first. I believe Olivia did try to incorporate some of those questions that were submitted in advance into the actual slides and get those answered there. If you're on the web browser, you go to your toolbar and go to the tab that questions, you can type it in and hit send. If you're on the mobile app, it's up in, I believe, the right corner. There's a little box with a question mark in it that you click to open up that tab. So I'm now going to turn it over to Olivia.
Perfect. Thanks so much, Tom. Hi, everybody. Thanks for joining today. So for our agenda items we're going to start out by doing a brief discussion over the expenditures for both Medicaid as a whole and then broken down into the pharmacy portions. Then jumping into diagnosis codes on pharmacy claims and when they are used appropriately and properly, they can significantly enhance your counseling, potentially open up MTM opportunities, and help us to avoid dangerous mistakes when it comes to medications. Next, we'll start in navigating a little bit of the medication therapy management, or MTM, and review some of what we've been seeing and how you can avoid some common mistakes. And then following that, we're just going to do a review of the newly updated HealthNet website and really focusing on the pharmacy web pages, and then a little bit of the pharmacy manual, and then end with a Q&A session with Josh. So like Tom said, if you have questions, feel free to put them in the chat and we will address them at the end. So at HealthNet, we operate in state fiscal years. So they start on July 1st of every year and then run through the end of, run until June 30th of the following year. So what you're seeing on the slide here is so far what we have for state fiscal year of 24. So July of 2023 through February of 2024 is what our data is showing. You'll see here that we're averaging about 13.5% of the entire Medicaid budget going into pharmacy. And this includes physician administered drugs, any and all claims billed by the retail or community pharmacy providers. And it does not include the claims that are billed by the hospitals and the clinics. So the bulk of it really is going to our retail and community pharmacy providers. One other thing that I wanted to mention in terms of budget is that approximately 1% of our budget is spent on administering the program. And that is far less than compared to other commercial insurance programs. And these types of admin costs that we're talking about include things from our actuarial services, our computer systems, the staffing, all of our vendors that help us out, things along those lines. So we truly are operating very efficiently, and any type of budget cut to Medicaid would impact the dollars that are spent on participants, as just 1% is paying for the overhead cost and 99% of our budget is being paid out to providing services to our participants. So next, the graph that you're seeing, this is just showing the growth of Medicaid over the years, and you can see that our expenditures have grown quite a bit year over year. So the big orange bar graph is the total Medicaid budget, and our population has also grown over time. So if you take a look at state fiscal year 21, our average population was roughly 1.09 million. And if you fast forward to just last year, fiscal year of 23, our population was 1.45 million. Now we're only partially through fiscal year of 24, but we do expect our population numbers to align very closely to those of last year, if not exceed or be a little bit higher. And the red line that you're seeing is actually our pharmacy spend. And so far we're at $1.4 billion this state fiscal year, and we anticipate that to exceed just over $2 billion. And just a reminder, this is for Missouri Medicaid alone and just for the drug expenditures. Now, if we just break down the pharmacy expenditures a little bit more, you'll see that whenever we look at them, they are on a financial cycle. And in this graph, you see a lot of peaks and valleys. So many of you are pharmacists or pharmacist owners on the call, and so you already know that we have, or we do, 2 fiscal payments or 2 fiscal cycles every single month. And not every single month does have the same amount of days. So there are occasions where you're paid for an extra week due to a 35-day versus a 28-day cycle. And you'll see that our specialty spend, which is the red colored bar, exceeds our non-specialty spend, which is the orange color bar, even though by and large, the majority of our volume is in our non-specialty spend. Moving on to diagnosis codes on pharmacy claims, back in 2020, we actually implemented a system change or an enhancement that allowed pharmacies to submit a diagnosis code with or on their pharmacy claim. And prior to that, HealthNet only accepted diagnosis codes on medical claims, and providers had to actually call the pharmacy help desk to ask for a manual override when they wanted to supply that type of information. Now, since 2020, this field has been optional, but a lot of systems were already set up with e-prescribing capabilities, where if an e-prescription would come over from a provider and it included a diagnosis code, the system would automatically pull over that diagnosis code and it would be sent to HealthNet for us to use and to look at in our adjudication process. But now looking or fast forwarding to January of 2024, we did implement a requirement on several different drug classes that now require a diagnosis code to be submitted. And you can see those drug classes listed there on the screen. Now, the medications that fall into these classes do have multiple indications, and they all have multiple dosing regimens depending on that type of, or what type of diagnosis they do have. So if we take a Humira as an example, it falls into the targeted immune modulators class on the screen. It has 9 different indications. In the adult population alone, there are 4 different dosing regimens, and in the kiddos, there are 3 different dosing regimens depending on what indication or diagnosis that they do have. So I highly encourage you to look at reference number 2. It's one of the hot tip references that I included. It goes into a lot more detail about this update, and you can learn a lot more about what's required using that resource. So why did HealthNet start requiring these diagnosis codes to be submitted? So we actually use very extensive medical information, including the diagnosis code, in the majority of our clinical and preferred drug list edits or fiscal edits. And we're really trying just to gain further insight into the actual real world utilization of the drug products, whether that be for on or off-labeled indications. And we hope to take this information and to use it to improve the transparent processing of our pharmacy claims for these select drugs and drug classes. And so what that means, that transparent process, it's really trying to make it easier, enhance your workflow in the pharmacies themselves. We also hope that pharmacists will be able to utilize the diagnosis code that's sent over to meaningfully enhance the pharmacist-patient provider interactions. So we really want to see you guys getting that information from the prescriber and then using that diagnosis in your process of reviewing the prescription and also educating the patient. So we all know that it's just not an aid in your educational efforts. We also hope that it helps reduce the provider burden by decreasing the number of times that you at the pharmacy or a prescriber must call the help desk. I'm sure many of you probably already know, but our average PA phone call is about 6 minutes right now. So on a little bit of a higher note, we actually have seen an increase in the amount of diagnosis codes that are coming in. A lot of that is driven by the e-prescriptions that we just talked about. And I know one of the questions that came in asked about us reaching out to providers. So we have been speaking at quite a few provider conferences to educate them on how great a diagnosis code is when it is included on a prescription, whether that be an e-prescription, a handwritten prescription, etc. So we really have been trying to make strides in that type of outreach. We all know that it's a lot easier on the pharmacist if there is a diagnosis code included on the prescription if a prescriber were to make a mistake. So if we take a prescription potentially for Flovent or Flonase, it would be really nice if the prescription had the diagnosis code so we could already determine if it was supposed to be for allergies or asthma. And then that would then help the or guide the pharmacist in that right direction on what the prescription was written for. So again, just trying to help avoid mistakes. We have created a cheat sheet, what we've been calling it, of do's and don'ts for diagnosis codes. We really wish that we didn't have to discuss some of the don'ts, but it's some things that we have seen lately in our data. So starting with the do's, make sure that you're only using a diagnosis code that is provided by the prescriber. And just as a reminder, the submitted diagnosis code on a claim is subject to audit. So the expectation is for the pharmacy staff to utilize the diagnosis code that's included on the prescription hard copy or to reach out to the prescriber to confirm the diagnosis code if one wasn't included and we are expecting one to be submitted. We also really urge you to talk to your software vendors, as we still have many pharmacies that are calling and telling us that their vendor doesn't support the submission of diagnosis codes, but diagnosis code submission is a standard part of the NCPDP transaction. So if your vendor is not supporting the submission of a diagnosis code, you should be worried about a lot of other things that your vendor is not supporting. Be sure that you are using billable diagnosis codes, and I will be diving into a few more examples here in just a minute. And then just lastly for the do's, do make sure that you're using this diagnosis to assist in your clinical review. Now for the don'ts. Please don't let your system automatically say, oh, this is a prescription for Olivia. We all know that she has hypertension. So I think that we should be submitting all of her claims with a diagnosis of hypertension, regardless if the claim coming through is for a flu shot or for Abilify. It really is a red flag on HealthNet's side that you're trying to circumvent the edit. We're able to see those types of things. Make sure that you are not assigning a diagnosis code for your patient on your own. We all know how easily Google, Yahoo, whatever web browser you're using, how easily it is for you to look up what a medication is used for. But what that happens is it throws off what, one, we believe the patient is using the medication for, and two, when we start to notice a pattern that you're potentially making up criteria on a prescription, that's whenever things start to sound a whole lot like insurance fraud, and that's not a avenue that you guys want to go down. So just as a reminder, in Missouri, pharmacists are not allowed to diagnose based on current rules and regulation. It's not within our scope, and by making up a diagnosis, you are going beyond your scope of practice. So just utilizing the diagnosis code is not a way for you guys to be able to circumvent the system or edits. This slide is more of an FYI slide for those of you that are needing some more guidance in talking to your switch or software vendors. This is a reference that I've included that talks about the requirement, what the field is, things along those lines. So again, more of an FYI. Moving into the billable versus non-billable diagnosis code examples that I was talking about. So that list did include, do use a billable diagnosis code. So before you submit an ICD-10 code on the pharmacy claim, you guys should be verifying that it is valid, it is billable. So taking a look at the code S62.5, this is for a fractured thumb. However, it's no longer specific enough. We now need a diagnosis code that tells us if it's the right versus the left thumb. Is the fracture proximal or distal? Is it displaced versus non-displaced? The list goes on and on. So in this example, S62.5 should not be used for reimbursement purposes, as there are multiple codes below it that contain a greater level of detail or a greater level of specificity. There are actually roughly around 100 billable codes under S62.5. And for those of you that do not know, ICD-10 codes are actually updated every October. And when I say updated, that means there are new ICD-10 codes available, some are removed. Many of them become much more specific. And again, that happens every October. And then just a reminder, don't be making up diagnosis codes on your own. They really need to be coming from the provider or prescriber. This again, just another example, the code F20 for schizophrenia is a non-billable code. It really does lack the full specificity needed to be billable. So you can see all the other billable codes that fall underneath it. So in terms of diagnosis codes, we have been evaluating what's been submitted to us. And for a lot of the part, or for most of the part, they've been good. Everything's been a valid diagnosis, or it's been a billable diagnosis that we can then actually take a look at the patient's history and match it up with a medical claim from the prescriber. However, we have noticed that sometimes the diagnosis code does not match the drug. Example being, we've seen claims come over for doxepin with a diagnosis of hypertension or Abilify for hypertension. Those just don't match up. But we do understand mistakes happen. But again, when we go back to seeing patterns or things happening over and over again, that's whenever HealthNet steps in and we take steps to address that type of behavior. So after implementation of this policy, we actually identified pharmacies and their staff finding different workarounds to apply diagnosis codes to the pharmacy claims inappropriately by either A, storing a default diagnosis code on a participant's profile with the expectation that this code would be then submitted with every single HealthNet pharmacy claim for that participant. So that example that I said, oh, Olivia has hypertension, every single one of her claims needs to be or have a diagnosis of hypertension on it. Or we noticed that pharmacies were looking up diagnosis codes online based on what would make sense for the medication prescribed without ever consulting the prescriber. So again, pharmacies were then flagged when a high percentage of their POS claims contained a diagnosis code that was not found anywhere in the participant's history. I'm not sure if you know this, but HealthNet can see every submission, every reversal of a POS pharmacy claim, and we can see that the only thing that's changed on a submission is the diagnosis code until you receive a paid claim. So again, there are a lot of ways that we are able to take a look at the system and be able to raise red flags when we see inappropriate behavior. This is one of the examples where the pharmacy was flagged where, in this example, all 87 claims that came over for this patient in calendar year of 23 had the exact same ICD-10 code on all of their prescriptions. You can easily run through this list and pick out the drug ICD-10 code mismatches. again, another example here where just a quick review, you can see that there, again, the drugs don't match the ICD-10 code that is submitted. And just as a reminder, the claims that have inappropriate diagnosis codes are subject to audit and are subject to recoupment. So just quickly, I'm briefly going to talk about this slide just a little bit. So this is another cheat sheet that we have created, and it's really used to help you determine which participants are eligible to receive the respective services, along with how to bill or who to bill. And I'm going to be walking through a little bit of these in greater detail in the upcoming slides. But before I do that, I just want to hit on the uptake of our pharmacist provider services. So we've actually had quite a few pharmacists interested in enrolling as individual MoHealthNet providers. And when they do this, you can bill MoHealthNet for prescriptions ordered by a pharmacist, including at-home COVID tests and nicotine replacement therapy. And so we actually have seen great growth in the number of enrollments. And we believe MoHealthNet has been a great advocate for this. And we're just happy to see it growing year over year. So as we have raised rates and pharmacists have really started to utilizing the service, we have brought reimbursement up to $1.4 million last year. We saw roughly 109 pharmacists billing for services, but we really want to see that gap close between the number of pharmacists that are enrolled and the number that are actually billing. We are only at 19% of enrolled pharmacists actually billing for services. So far in 2024, we have seen roughly $500,000 in reimbursement. So we do believe that we will exceed what we paid last year. Only time will tell. Now, with this uptake, it does unfortunately mean that we are seeing some inappropriate billing, and that all comes with audits. So just a few reminders as you start to utilize provider or pharmacist provider services. So there are just a few steps that need to be taken to, one, make sure that you are ensuring reimbursement is granted, and number two, that the services that are being provided can stand up against any potential audit. So you need to be making sure that you are verifying eligibility through EmoMed. Make sure that you're documenting the service within a medical record, and this documentation needs to be complete, legible, and concise. Make sure you're taking a look at the fee schedule for any covered CPT codes and reimbursement rates. Just a reminder, medical claims can be submitted through either the pharmacist provider's medical system or through EmoMed. And then just lastly, the pharmacist provider needs to be listed as the performing provider. And I'm going to read that again. The pharmacist provider needs to be listed as the performing provider. We've had lots of questions of where the pharmacist needs to be placed on the claim. So in terms of the billing provider, that truly depends on the agreement between the pharmacy and the pharmacist. If the expectation is for the pharmacy to get paid for the service, they need to be listed as the billing provider. If the expectation is for the individual pharmacist to be paid for the service, then the pharmacist needs to be listed as the billing provider. So overall, just before you perform any type of service, please take a look at the two references that I have on the screen. That's going to be the manual and then our bulletin. And make sure that you are really reading through it. We still get numerous phone calls to our pharmacy administration unit asking questions, even though the answers are present in those two resources that are provided. Prior to the webinar, we did have a question come across on any additional resources on how to submit claims in EmoMed when a medication is administered by a pharmacist. We actually have a full PowerPoint presentation available, so please check out the link there and take a look. If you have more questions, reach out, but I'm not going into this one in a lot of detail. I just want to run over 3 different examples of some audits that we're seeing, especially related to the medication therapy management codes or MTM codes. So the pharmacy manual reads, participants residing in a setting where an individual needs medical or long-term care services are not eligible for MTM services. And we want to reiterate that this does not include participants in group homes with no level of care on their profile. So if you look up a patient in EmoMed, there is no level of care on their profile. This does not indicate that they're eligible for services, especially like I said, if they're residing in a group home, they're still ineligible for services. Example 2, where we have seen participants are receiving or supposedly receiving more than the limit of 4 MTM units per month. Again, we did have a question before the webinar asking if it was 4 units per rolling versus calendar month, and we will be updating the manual with the language that says it's 4 units per rolling month per provider. So wanted to make that small call out as well. We've also have decided to adopt the rule of 8 when it comes to billing of the MTM units. So we've had questions asking, if I were to spend only 16 minutes with a participant, do I bill for 1 unit or for 2 units? Because these are supposed to be 15-minute increments. So in this scenario, if we're utilizing the rule of 8, you'll see that that should be billed as 1 unit. And the third example, this one is just to remind everybody that the MTM codes are very specific. The one code that I have on the screen, 99605, this is for initial encounters for a new patient to become established. However, we are seeing this one being billed month after month for patients that have already received services from the same provider. There actually are other codes for subsequent monthly visits, quarterly, yearly, however often you're seeing or providing these services to these patients. So just be sure to utilize the correct code when you are paying. So the 99605 is only payable 1 time per participant, per lifetime, per provider. I also want to point out that the MTM codes are billable for face-to-face time with the patient, and that includes things along the lines of FaceTime or Zoom or other platforms that you may utilize. Now, what doesn't count as a billable encounter is whenever you say, oh, I sat in the back office and I did a bunch of paperwork on a patient, or I wrote up a bunch of notes for 8 patients. Those are not billable MTM hours. The MTM hours at the rate that we are paying is set to account for the total time that you're needing to provide the service to the patient. So again, it's a 15-minute code, but if you stop and then spend 3 hours for the paperwork, we're not going to be reimbursing you separately for the 3 hours that it took you to complete said paperwork. Just as a reminder, HealthNet and the Missouri Medicaid Audit and Compliance, or MMAC, we work hand in hand to review claims, and we have started to exponentially review pharmacy claims a lot more between diagnosis codes and our MTM billing issues that we have seen. So just some things to expect moving forward. There may be communication received from HealthNet Pharmacy Integrity. The email there is on the screen. That's actually an inbox that I co-monitor. So you may receive either emails from us or letters from the pharmacy unit, or even phone calls asking for medical records to be sent in. Just of a note, those must be returned within 10 days after the request. That is written into regulation, and no HIPAA release is required for or from the participant. And then after we go through our audits, just be aware that administrative action may be imposed depending on the type of finding, or if there is no finding. Okay, time check. So just looking down. So we have, now I'm going to be walking through the updates that happened to the website or the web pages, and we're only going to be looking at the pharmacy specific ones. All of these titles, or the majority of the titles on the slides, are in green. That is indicative of a hyperlink, but I do know whenever things get converted into PDF, sometimes those hyperlinks don't work like we want them to. So I have included links so you can type them into your web browser and go directly to the pages that I'm talking about. Note that all is listed there in the left part of the screen. So the web page was updated in early 2024. And I'm sure a lot of you have already seen the updates that have happened. If you go to our pharmacy homepage, you will see that there are 3 different buttons, so the preferred drug list and edits, a committees button, along with the manufacturer's button. I will go into those in just a little bit. If you were to scroll down on the home page, on the left side, you'll see multiple different education and training opportunities. There is a direct link to that pharmacy billing medical claims reference that we talked about earlier. On the bottom left, we have access to all of our forms. The majority of these are all the prior authorization forms that you may need to utilize in the PA process. On the right hand of the screen, you'll see we have the provider manual along with a general section portion, and I'll hit on that in a minute. And then lastly is the resources section. A lot of you may have used the link frequently updated documents. A lot of those resources have been placed here, and that's where you will find that information. So just a quick tidbit on the pharmacy manual. All of our manuals, all the provider manuals did undergo a overhaul to the end of 2023, beginning of 2024. So you may see a different look and feel to all of the manuals. I just wanted to make a recommendation. Whenever you click on the pharmacy manual, it includes a ton of great information, but some of the information that we had deemed to be general information or that applies across all of the program has been moved into a general section, and that's the second little bullet point there. So make sure that you're not only just reviewing the pharmacy manual, but also the generals sections, because it applies to multiple program types. We did have a question on who or where was the best place to reach out to if you had questions regarding the pharmacy provider manual. And that's going to be to reach out to the pharmacy administration unit. I have their contact information at the end of the slides, and I'll keep pounding on that point. If you have questions related to HealthNet Pharmacy and it's outside of the PA process, so you have billing, questions about policy, reach out to the pharmacy administration unit. You'll hear us lovingly call them PAU. So if you ever wonder what that is, it's a lovely in-house group of individuals that will answer your emails, answer your phone calls. They're just a great resource that not a lot of providers are utilizing. So if you were to scroll down, we're still on the pharmacy home page. It has a section where it's just HealthNet news. What I'm showing you on the screen includes all different program information, but you can see I have circled in red specific pharmacy relevant information. So you have bulletins, different hot tips. You can scroll through. It's got all kinds of information from multiple quarters. But if you were to actually click on the HealthNet news main page, you can go there and you can actually search 10 years of information by date, type, program, or even keyword. And again, 10 years worth of information there. So highly recommend you utilize that resource. If you do want to stay up to date or receive all of this news directly to your inbox, you can subscribe to get the HealthNet news sent directly to your email. So I have circled there the subscribe button. It will bring up a separate web page where you can type in your email and subscribe. If you are unsure if you already have subscribed, go ahead and still type in your email address. What it will do will say, oh, congratulations, you've already subscribed or you have been subscribed, but now it also allows you to change your preferences. So at the beginning, you said, I want all of HealthNet news, and you've now decided, no, I really only want pharmacy information. You can select that specific box just to receive pharmacy relevant information. So now moving on to the very first button that you'd see at the top of the page is going to be the preferred drug list and edits page. So what that's going to do is just going to give you a quick overview about the program, our utilization management edits, things along those lines. And you'll find 4 new radio dial buttons, or just radio buttons: the implementation schedule, the PDL and diabetic supply searchable database button, a link to the preferred and non-preferred products listing, and then also the drug prior authorization forms. And I will go back through those in just a minute. So if you were on that page and you continued to scroll down, what you would find is all of our documents that contain any type of requirement or criteria that's needed for the prior authorization process or policy process. What you can do is you can search the titles only. Unfortunately, we're hoping that maybe one day we will have functionality where you can search within the documents themselves, but right now the search bar only applies to titles. If you do look on the right side of the screen, there's a column for upcoming policy changes. We do a big round of renewals every single quarter. So there's one in January, April, July, and October. And about a week before that change, we include a new link that has new criteria for anything that is going to change. So you will find that information there so you can be prepared for that type of change. And then I don't have an example here on the screen, but if you were to search the CGM criteria underneath that web document, or the document that has all the criteria, there is a link directly to the PA form that's relevant. So as you scroll through these or look through these, a lot of them will contain the needed PA form right underneath it. So quick and easy to access. All right. Envisioning that we clicked the implementation schedule button, we'll actually pull up a PDF. And what this tells us is after our quarterly meetings, and those all happen in, again, January, April, July, and October, you can see the anticipated date of that change. So the effective date there on the right. You may notice that all of these, or the majority of them, are a Thursday morning. So HealthNet makes the majority of our policy or criteria changes on a Thursday morning. And many of you may have been able to figure that out based on the increases in number of calls that you need to make to our help desk on a Thursday morning. Now, envisioning, we clicked on the PDL and diabetic supply searchable database button. This is not a new website, so this will take you to a different website, but it's housed by our PDL vendor, Gainwell Technologies. Again, this specific website is not new, but for those of you that didn't know where it had moved to or the direct link to it or some of its functionality, I'll quickly run through. So you can search for a PDL or diabetic supply by the NDC, the brand name, or the generic name. Now, either the brand or generic name fields have to have at least 3 characters for it to be a search. And one other thing that I wanted to point out that I'm not sure a lot of people know is that date functionality, you can actually change it to look at a historical PDL status or drug coverage at an earlier point in time. Also, if you were to pull up this webpage on your phone, it is mobile friendly, so it would look and feel or act very similar to what you would see as if you were utilizing it on a computer. On to the preferred and non-preferred products link here. This is actually just a listing of all the preferred products. It also includes them by the PDL class, whether or not they're preferred or non-preferred, and also the anticipated review date. So we actually take medications quarterly to our DPAC and DUR boards, and that is the anticipated date for those meetings. Within this document, whenever you have them pulled up like this does include a search functionality, so you can look for specific medications here. Another great thing that we tried to include with the updates to the website is if you have a link or a direct link, let's say, to this listing, and we change the document but don't change the name of the document, the link will remain active. So you have it, and as it changes, it will change with you, or the link will automatically update the document within. And then just the last one here, if you hit the drug prior authorization forms, it's actually going to take you back to the main page and show you all of the forms. Like I said earlier, the majority of these are found within, or right underneath its needed criteria document. So now on to our committees page. If you ever want to learn more about HealthNet, the pharmacy benefits specifically, we do welcome all stakeholders and even the public to join us at these quarterly advisory meetings where we do review coverage criteria, drug utilization trends, and make any type of necessary changes based off of changes in guidelines or updates to PIs, things along those lines. So with that, if you were to hit the committees button, it will bring up the meetings that are relevant to pharmacy. So you have the Drug Prior Authorization Committee, or DPAC, the Drug Utilization Review Board, or DUR. And then we also have the Advisory Council on Rare Diseases and Personalized Medicine, or our Rare Disease Board, or RDAC. You can sometimes hear us refer to those. And if you were to click on the right-hand side on that arrow, it does provide a little bit of a drop down, and it goes over what the committee is, what type, like how it was established, things along those lines. But at the bottom is where we want to draw your attention, where you can learn about the committee members themselves, but also gain access to all of the meeting information and meeting materials. So if we were to click on the meeting informations bullet, it would bring up all of the relevant information that we're going to be going over or presented at that committee meeting. So we did just recently have one, April 16th, and you can see all of the information that was presented. This is only a tiny screenshot. The list goes on and on and on of all of the proposals that we brought to the committee. Here you can also register to provide a public comment. We do allow for the opportunity of clinically relevant public comment for up to 5 minutes presented to our boards. And if you were to click the register button, you can see all of the information that is needed to provide your public testimony. And then just as an FYI, I thought I hit the button too many times. I think we're still okay. At the bottom of almost every single web page, you will see an option to click Calendar of Events. And what that will do, it will pull up a calendar for the entire Department of Social Services. So I've got here on the screen the example for April of 2024. And you can see on April 10th, we held our rare disease meeting. The 16th was our drug prior authorization meeting, and the 17th was our drug utilization review board. If you were to click on those meetings, you would actually find the WebEx information, so you can log into the WebEx and join and listen in, or actually participate. And then they also have a add to calendar functionality, so you can get that added to your calendar, be alerted of when it starts and that it's upcoming. So I just have a few more slides here. The who you're gonna call. It's not gonna be the Ghostbusters. It's going to be, again, the Pharmacy Administration Unit when you have any type of billing question or an issue that's unrelated to a prior authorization. So again, we mentioned who you're gonna call if you have issues with the pharmacy manual or you have questions about it, policy, things along those lines. So I've included the contact information, the email, and the phone number are gonna be the easiest ways to get a hold of us. Again, this is in the slides, in the handout, so make sure you save them so you can have that information. And then lastly, before we open it up to the Q&A, just a few things that are up and coming and on the horizon. We do hope to have quite a few educational opportunities that will be available on the website at any point in time, going over either improper or proper billing practices, and then along with the medication therapy management, just some more educational opportunities there. And if at any point in time you have a resource or you see a current resource that we could improve on, like an educational resource, you can feel free to reach out and let us know. So I've included the education email there on the screen as well. And then one last tidbit, during this past legislative session, MAC, who is in charge of the provider enrollment, did receive budget authority to proceed with implementation of a 100% electronic provider enrollment system. And they really hope to have that system implemented and operational in mid to late 2025. So just something to keep on your radar. So now I will pass it on over to Josh.
Thank you, Olivia. We will now switch over to Josh. He's going to take questions. He's going to start with the ones that were submitted in advance. If you'd like to send a question to us from the GoToWebinar app, you can go on your web browser there or on the mobile app by clicking the little question mark in the box at the top right. So we'll now switch it over to Josh.
All right, thank you, Tom, and thank you, Olivia, for that overview and in-depth presentation. Really appreciate it, and think you did a good job. A couple of the questions that we've received over the last couple of weeks in anticipation of this call. The first one was, how do you medically bill for immunization administration? Before I answer that question, I want to make sure that we are very clear with pharmacists that you either submit the claim through your point of sale system or you medically bill for the claim. You do not do both. So you do not submit for the ingredient through your point of sale and then submit a medical claim for the administration. You would do one or the other. We do have an active report that we run, and we would recoup any funds that may have slipped through accidentally if you double bill, since that is double dipping. Instructions on how to medically bill vaccines, though, are included in the physician manual. If you look at the pharmacy manual under vaccines, we talk about how vaccines are billed, and then we refer out to the physician manual for further in-depth instructions. We received the question for documentation requirements for PPS. If the intervention is done over the phone, is the signature requirement waived? I'll remind people that patient signature or retrievable electronic verification of services received is required. There is no waiver for services provided via telehealth. The provider must have a system in place to produce the documentation if requested upon audit. We received a question on the website. It would be helpful if there were more answers, i.e. patient needs to try and fail X number of medications, how many months people need to be on a certain medicine, or what other medications patients need to try and fail. I think Olivia did a really good job going over the website in terms of where that criteria can be found. If there are further questions, feel free to reach out. Please review the SABA dispensing policies and limitations, and if a PA is approvable for usage outside the guidelines. Again, this information is located on our website, but we will remind those on the call, we apply albuterol limits in terms of a limit per 6 months to adults. So those would be defined as greater than or equal to 18 years of age. We do exclude patients that have a diagnosis of cystic fibrosis. So for those adults that are 18 and older, do not have a diagnosis of CF, we limit to 3 inhalers per 6 months or 180 days. For patients that do have a diagnosis of COPD, we limit to 3 inhalers per 90 days. However, we require them to have the diagnosis of COPD and be on concurrent COPD maintenance inhaler therapy. And we do have details on that on the website on the albuterol SABA policy. Can you review Medicaid's stance on filling prescriptions on cash due to not meeting Medicaid's requirements or step therapy? HealthNet does not have a requirement that participants are unable to receive a product or service not paid for by HealthNet. I know that other states may have that limitation in place, but Missouri is not one of those states. We had another question come in, how to get reimbursed the dispensing fee on compounds. I'd like to remind providers and pharmacies that when you submit a compound, make sure the active ingredient is first. The active ingredient must be something that is payable. So there are some ingredients out there that HealthNet does not pay for, especially in the bulk powder category. So if it's a bulk powder that we do not pay for that's being placed in the first position, you're likely not going to get a dispensing fee. And then the submitted cost must exceed the allowed amount. So if you submit a cost of 1 penny and that's the total penny price that you submit to us, we would not then pay you the $12. The submitted amount needs to exceed the dispensing fee amount. If you still have questions and more specifics that you want to work through, contact our provider or pharmacy administration unit help desk via email or phone call. Some of these do require a phone call as it may be more specific than what you can get through an email. We also noticed at the beginning of the call, there was a question that said the GI motility PDL link was routing people over to the GLP-1 PDL policy instead. Since we've been sitting here, that's actually been fixed. So hopefully you are now able to get to the right policy. We appreciate that outreach. couple of comments came in that there were issues in DC Pro in terms of claims being denied or not being able to be submitted properly. We are aware of this issue and we have all hands on deck trying to get that fixed, and we'll let providers know once it is fixed. Got a question on the chat. Can we bill for services under MTM if it is a phone call, or must it be two-way video if remote? I would refer you back to the telehealth statute. That's 191.1145. If you review that and still have questions, please let us know. How can we tell if a patient is eligible for MTM services and what services? So on the MTM services that the patient's eligible for, there are a few things that you're going to want to look to in EmoMed. I highly recommend you take the training in terms of what to look for to determine patient eligibility. I think as pharmacists, and myself included as I worked the bench a number of years ago, we didn't ever really worry about patient eligibility because the claim paying really told us if the patient was eligible or not. For these services, what you're going to have to get into the mindset of is much like a clinic or an office visit. Those office visits, they are checking eligibility before the patient comes in. There's a number of ways that you can do that. So please attend one of our webinars and trainings on how to check eligibility and what those various indicators mean, because it does get quite complex, especially when you start looking at patients that have other third-party liability. They may have spend down, and we do have day-specific eligibility. So a participant could be eligible today, not eligible tomorrow, and eligible again the next day. So it is very important that you are checking eligibility, because we do want to make sure when you are providing these services that you do get paid for it. And eligibility is not one of those things that we can override like you may get on a prior authorization. Next question is in terms of documentation. If you're solely providing MTM services through DC Pro, is there a requirement to document in the pharmacy system as well, or is the DC Pro documentation sufficient? I recommend that you harvest enough data that if you are audited, you have that information available for audit purposes. So if in 10 years, or not 10 years, in a couple of years, if you're not able to access that website, you would have no documentation available. You need to have documentation available and on hand if there is an audit to support what you billed us for. Next question is, do DC Pro and EmoMed claims get paid same as pharmacy claims to the PAC and show up on RAs? Yes, they do show up on the RA. If you have been billing your DC Pro claims and have the billing provider be your pharmacy that is enrolled with the PAC, that money should flow through the PAC and be on the RA that you receive. Now, we get a lot of questions about, did you actually pay me for this service? Because most pharmacies are going to have a lot of point of sale pharmacy claims and very few DC Pro or MTM claims. So it's easy to, as you're reviewing those, lose sight and pass over the MTM claims. So review those closely. Next question, will the copays to patient ever be back? I do not have a crystal ball. I cannot tell you ever. At this time, we do not have plans to bring the copay back for pharmacy services. I will tell you that if they did ever come back in the future, it would be different than what was done in the past in terms of the copay. Prior to COVID, when the copay was collected, that money was in addition to the full dispensing fee and the full allowed amount that the pharmacy was being paid. If copays came back, the copay would be a reduction of the allowed amount. So if it was a $2 copay and the allowed amount was $100, we would pay the pharmacy $98 and expect the pharmacy to collect the $2 from the participant, instead of paying the pharmacy $100 and then the $2 extra coming from the participant. Next question is about reconciliation process of claims submitted through DC Pro and payment receipt and the RA. That is really going to be up to the pharmacy in terms of how they're going to be accounting for it. there should already be something in place in the pharmacy, I hope, in terms of reconciling what you're getting paid for on the pharmacy drug side of things and making sure that you are getting the dollars and receipt in. Okay, next one. Having to read these are a little bit longer than the others. Okay. Next one is about HealthNet has preferred manufacturers for certain medications. Why can't HealthNet help desk representatives tell pharmacists what NDC exactly is covered? Our expectation is that the pharmacy bill us for the NDC that they have, not the one that they know will actually pay the claim. That being said, if you go to our PDL searchable database that Olivia went over, that does have the exact NDC that we are preferring. I can tell you that that is an incredibly complex website, as it can change weekly. And not all NDCs that the manufacturers report ultimately are payable and distributed broadly. Some of those are institutional use only, some are samples, etc. So we do have to scrub a lot of those out as we go through the process to make sure that they're not showing up for an institutional NDC to be ultimately submitted as an outpatient pharmacy claim at your local chain drugstore. I think we're out of time.
Okay. Well, I'm gonna let's move on here. So our next webinar is going to be May 16th. The DEA will be coming to give an update. I will tell you at this time, I do not believe they're going to take live questions. So the announcements will tell you to send your questions in advance if you have any for the DEA. I'll probably send out the alert to register for this next week, so be on the lookout for that. We do, as I mentioned earlier, we do record our webinars. There should be a recording of this webinar within 15 days on our website. And if you go to the section of videos and webinars, it'll show up there. If you want CE for today's program, if you're on the web browser, don't close your browser. A little screen will pop up that you need to click close on. And then again, don't close your browser and the survey will pop up. If you're on the mobile app, it pops up automatically. You don't have to do anything on that. Answer the questions and click submit on that. If you do not get the questions, the post-survey questions, you can email us at compliance@pr.mo.gov. We will email them to you, but you must get them back to us within 24 hours if you want to receive CE credit. We will email your certificate in approximately 30 days. And again, a reminder, we do not report to the CPE monitor, so make sure you save your certificates. I want to thank both Olivia and Josh for coming today and giving us an update from the HealthNet pharmacy program. And we look forward to you coming back next year, hopefully, and giving us another one. So I'm now going to end the webinar for everyone.